Thank you for joining us for our pre-recorded Zoom meeting, an educational platform about COVID-19 and where do we go from here. Recorded on Monday, September 21, 2020. This Zoom meeting is featuring Dr. Thomas Lawrence, System Medical Director of Geriatric Medicine and Long-Term Care for Mainline Health, and who has been the Medical Director for Kendall Crosslands Communities for over 20 years. His full bio may be found as an attachment to this Zoom meeting communication. Also joining us today are Lisa Marsilio, Chief Executive Officer, and Donna Taylor, Chief Health Services Officer for Kendall Crosslands Communities. I am Michelle Berardi, Director of Communications and Public Relations, and I will be your moderator. Our educational program today will feature questions for Dr. Lawrence about COVID-19 and the 6 months into this pandemic, and where do we go from here? Questions have been submitted prior to this meeting and were collected from residents and staff of Kendall Crosslands Communities. Thank you, Dr. Lawrence, for joining us today. It was early May when we first hosted you for a video, and what a journey it has been since.
Right.
We know that you're very busy, and even more so during this pandemic time. And again, thank you for guiding us through these unprecedented times when information and best practices are evolving and changing daily, and as we learn more about COVID-19. So let's get started. Dr. Lawrence, you are also the medical director for many other retirement communities, and you have a pulse on the regional medical systems. It would be helpful if you could share with us your perspective of how KCC is faring in this pandemic and the overall picture of what other CCRCs are doing. Help us to understand what the emergency room situations are at our area hospitals and our cases rising in Chester County.
Okay, well, thank you. It's a pleasure to be here to be able to talk to everybody again. The good news is, and I'll start with the hospital side and the acute care side, is that the number of cases in the hospitals, especially mainline healthcare hospitals, has reduced greatly in the last 2 months. There are relatively few cases. There are still people on ventilators with COVID-related acute respiratory failure. But the number of cases has diminished greatly. And many of us believe that that is in part because the nature of the virus that's currently circulating, or the strain of the virus that's currently circulating, seems to not be quite as aggressive as it was 3 and 4 months ago, where we saw the hospitals overwhelmed with cases, the ICUs overwhelmed with cases, with more than a dozen people on ventilators in any given hospital related to COVID infection. And that has really just changed completely. Yet in the community, even though things have quieted down considerably in our area compared to 3 or 4 months ago, COVID is still on the rise. And in fact, in our county, Chester County, and in area counties, we see that things are progressing a bit. There are more cases. It is not to the extent where it's alarming, but nobody knows quite where things are going to go. Nobody knows quite whether this is due to a change in the behavior of the current strain of the virus, or whether it has something to do with warmer weather, or whether it's just that it has gone elsewhere and it's going to be coming back. We know that colleges are having more and more cases. The colleges that are open to in some fashion are struggling to stay open. Whether they'll be able to do that long term is unclear. As you know, most of the schools in the area are not having live gatherings of students. But there's a concern that we're not quite sure where things are going in the next month or two, but certainly things have quieted down considerably. The concern, though, is that things are going to be coming back. Kendall and Crosslands communities have done extraordinarily well. We've been very aggressive, as have many of the retirement communities in our region, with distancing, avoiding social gathering, and other protections, including not having group dining in large dining rooms, for example, to protect the residents of retirement communities We don't, unfortunately, have a lot of hope that major changes in opening up are on the horizon. Until there's a vaccine, which I think we'll talk about shortly, we are fighting this battle extremely cautiously and advancing and expanding people's ability to gather and do things more relatively slowly. We've been had great fortune in that we have not had a lot of cases or significant outbreak in our communities, and our goal is to keep it that way until a vaccine is available 2, 3, 4, 6 months from now. We're not sure. There are other, of course, Delaware Valley is the world's capital for continuing care retirement communities, and we see a variety of other retirement communities in the area trying to open up. Some have allowed more visitation. Oddly enough, there seems to be a pattern that for-profit facilities are opening up earlier than not-for-profit facilities. I don't know what to make of that, but it's been a pattern that we've seen. We can only say at this time that there's really no clear, safe path forward to opening up. Any measures that we do are very cautious, more or less experiment, because we don't have clear guidance on what is safe. The concern being that as the younger people in the surrounding community start to engage more and open up and be more social and less distanced, that's going to cause the virus to come back on all of us. One of the issues with our dining rooms, of course, is that we have young people, often high school students, as servers in the dining room. And that is the population of Americans who perhaps is at highest risk for developing COVID infection. Serving the population of Americans who are perhaps at the highest risk of acquiring COVID infection and bad outcomes related to COVID infection. So it's a very, very careful, cautious situation we find ourselves in. But we cannot say with certainty how safe it is to progress with opening up. And with the coming of fall, students back in school, it can be a couple weeks till we see what happens. And so we're more or less holding our breath now. As we'll talk about, I'm sure shortly, there's going to be more and more testing required of nursing facility staff, for example. So we're going to see more and more cases. There tend to be more and more cases of people who test positive but who have no symptoms. A dangerous situation because we can't identify them other than with routine testing to know that they're there and they may be infectious and spreading the virus to others. So good news is things are quiet in the hospitals, but we're very cautiously looking literally day by day to see how things go in the communities. I think Kendall Crosslands Community's plan for going forward is as safe as we can make it at this time, and we ask for everybody to be patient with this. We've been in this for 6 months. It may only be 2 or 3 or 4 months until we have a vaccine. So there is light at the end of the tunnel, but we're not quite there yet.
Thank you, Dr. Lawrence. Dr. Lawrence, new regulations continue to come out on testing, in particular, the recent one on the frequency of testing based on local county transmission. As a geriatric medicine specialist, can you share your perspective and those of your colleagues in the medical field on current testing protocols? Examples might be the testing equipment, the different types of tests, antigen, PCR, the principles, the barriers.
Sure. So there are 2 basic types of tests. The PCR nasal swab, which measures RNA, which is a molecular material from the virus that can be identified specific to the virus. That's the type of test most of you have heard about and some of you have had done. It's a deep nasal swab, and it takes between 2 days and a week to get the results back. But it's the best test there is. There are now rapid antigen tests. Antigen tests certain proteins on the surface of the virus not a direct measure of the nuclear material of the virus, but of proteins that are associated. Antigen tests can be faster. They can take 20, 30 minutes to complete, but they are not as good. They're not as sensitive, meaning not all cases of active infection are picked up as positive. So you can have so-called false negative cases where the test is negative, even though there's actually COVID infection present. So the antigen tests are a poor substitute for the PCR testing, but they are more readily available and will be more available in the future. They're less expensive and they're faster. But again, we hope to only need to use these if PCR, the traditional testing, is not available. Antibody testing you've heard about has nothing to do with diagnosing whether somebody has active infection, so I'm not going to talk about that along with these other tests. Recently, there was a new federal regulation for nursing facilities requiring nursing facilities to test all of their staff on a regular basis. You probably have heard that back in June and July, there was a requirement that everybody in nursing facilities be tested at least once. We went through, I think, 4 rounds of testing at least because we identified a few asymptomatic staff members. So we had to keep going every week with testing until there were no more positive cases identified. Now the requirement is that it be at least monthly, but shift to weekly should the test positivity rate in Chester County, the county where the facility is, goes above 5%. And what that means is that of all the tests reported to the county, if there are more than 5% of all tests that are positive, then the facility would have to shift to weekly testing, which is tremendously difficult because it would be weekly testing. Usually that would mean for a period of at least a couple of weeks, if not a month and more. And again, there won't be any end to these rounds of testing until the pandemic is really cleared with vaccine, and that could take months and months. So there are these new requirements for testing. We hope to be able to use PCR testing. Antigen testing, not quite as good, can be used if we have a shortage of PCR testing. Many antigen tests, depending on the situation and how prevalent the infection is in our surrounding community, may need to be repeated with a PCR test if they're positive, in some cases if they're negative. Very complicated. We won't be able to go into that, but just know that the testing is quite complicated. Residents frequently ask, well, why can't residents be tested? Well, the problem with testing is it tells you on any given moment of testing whether people are positive or not. It doesn't tell you whether that same person is going to be positive tomorrow or next week. And residents of retirement communities are actually at lowest risk because of everything we've done in terms of protecting our residents to have COVID infection. So testing people at very low risk actually creates more problems because when the risk is very low, you can get what are called false positive tests that comes back positive, and really the person does not have infection, but then they're committed to being quarantined for extended periods, and there's more and more rounds of testing. So no one in the world is recommending testing of residents of independent living retirement communities who have been carefully avoiding gathering, wearing masks everywhere, avoiding contact with others, and all of the protective strategies that we put in place over the last, 6 months. So there's going to be more and more testing. We're going to be identifying more and more people who may have more in the way of asymptomatic infection, and they'll be out of work for at least 10 days. Many other people who are their contacts will be quarantined for 14 days, sometimes on top of that 10 days. So it gets complicated, but know that testing is actually going to be expanding greatly, including among our staff members.
Dr. Lawrence, if the recent medical reports of insufficient enrollment in vaccine clinical trials of varying ages, comorbidities, ethnicities are accurate, and the speed at which a vaccine is being tested and ultimately produced, how should one evaluate the safety and efficacy of early vaccines?
So about 10 days ago, the first results of the first vaccine trials from China were published in the Journal of the American Medical Association. And in that trial, which was so-called phase 1 and 2 trials, looking at, is the vaccine tolerated, what are the basic side effects, what is the immune response to the vaccine in terms of producing antibodies. It's not the phase 3 vaccine trial that tells us that in fact the vaccine prevents COVID infection and prevents COVID outbreaks. That's what we're waiting for. But these trials from China only included people between the ages of 18 and 59. So it doesn't tell us how an 85-year-old, for example, might respond to the vaccine or what types of side effects they might have from the vaccine. So it turns out, in fact, that's not just true of vaccine trials enrolling younger people. It's actually true of almost all medication trials. They tend to enroll younger people and older people who may have multiple chronic conditions or be frail or of extreme age, over age 85 or 90 even, are typically excluded from those types of trials because it's more difficult to figure out whether a medication or a vaccine is working in somebody who has lots of medical problems and could have symptoms that you can't tell whether it's a symptom related to a medical problem that they've had, a chronic medical problem, or a reaction to a vaccine or medication. So we're more or less stuck with a situation that the vaccines that will be developed will have limited, if any, testing in very elderly or senior people. Okay, so how do we tell if it's safe in seniors? Well, there's a number of ways. There's a number of government healthcare agencies. First of all, the FDA. The FDA, before it approves anything, including a vaccine, will look at all the studies that have been done and do their best to be certain that a vaccine is safe and effective. Then there's the CDC, which weighs in all that also and makes recommendations about vaccine administration based on all of those studies and ongoing studies, because they continue to watch the effect of vaccination and its outcomes well after a vaccine is marketed. Then you have CMS, Medicare, who certainly for nursing facilities, which, CMS is the Centers for Medicaid. Medicare is the chief regulatory agency for nursing facilities. They'll have guidance and recommendations available. Then the medical literature, including the lead articles like the New England Journal of Medicine and the Journal of the American Medical Association, JAMA, will publish and have editorials on experts around the country giving their opinion on whether any given vaccine is safe and effective. In addition, the State Department of Health, the local health department, facility medical directors like myself, infectious disease specialists at our area hospitals and health systems will all be giving opinions as to whether the vaccines that come down as the first available appear to be safe and effective. So there's literally thousands and thousands of American experts scrutinizing these vaccines as they'll become available and determining whether, as best we can tell, they appear to be safe and effective. I'll say this, as you probably heard, seniors will be one of the highest priority groups to receive the first round of the vaccine because seniors are at greatest risk of the infection and its various complications. Seniors are at greatest risk because many live in congregate settings like retirement communities, okay, or personal care facilities or nursing facilities. So it puts them at higher risk for infection. So know that seniors will be among the groups that have first access to vaccines, along with healthcare providers, first responders like firemen and EMS professionals, certain government people, our military, So all the most vital people in the country are going to be first in line for vaccines. So there'll be a lot of people looking at, as best we can tell, the vaccines are safe and effective as they come forward.
Thank you. Dr. Lawrence, we've instructed residents over the past several months to keep group gatherings outdoors, use technology as much as possible to gather, only be indoors with other persons at a minimum, wear a mask, socially distance yourself. With the cold weather soon coming, can you discuss the conditions and the rationale for group activities indoors where aerosols might persist to the extent that we could be at risk of airborne spread in public spaces or inside our main center, all coupled with our congregate living setting?
Well, I'll first respond as our chief of infectious diseases at Mainline Health would respond to the question, is it safe to do more inside and in larger, in groups of 5 or 10 people as the weather turns cold? And his answer would be, who knows? We don't know. We don't know what's safe. Basically, what we're going to be recommending is a very cautious move forward. But know that we can't guarantee safety because we just don't know. We don't know how the virus is going to behave with change in season as we go forward. So we're going to be very cautious, but there's no clear, safe path forward. So we're going very cautiously and watching things very carefully. And this will be happening while our staff members are being regularly tested. So stay tuned. If we have an outbreak among 1 or 2 of our servers in the dining room, for example, or that would completely limit our ability to open up group dining, for example. And that happened at a facility in the area recently where a housekeeper came down with COVID infection. I was wearing a mask. The residents whose apartments went into was wearing a mask, but then suddenly we had 10 or more residents who had to be quarantined, watching carefully for any signs of infection for the next 14 days. So, every step forward, there may be 1 or 2 steps back. So stay tuned and be patient is the best, advice I can offer.
Thank you. Dr. Lawrence, can you explain why we should continue to quarantine when residents are admitted after a hospital stay, and why the quarantine is a bit longer for residents who reside in our health centers when strict protocols for testing before, during, and after a hospital stay are conducted?
So as you probably heard, a person can develop COVID-19 infection anytime within 14 days after exposure to somebody else who has the infection. And testing just tells us on the day of testing whether they had virus detectable or not. It doesn't tell us the day after or the day after that. So there's a window of 14 days that a person could develop COVID infection anytime they've been exposed to others or groups of people, certainly anytime they've been exposed to a known case. But anybody who's been in the hospital, because there are COVID cases in hospitals, even though there are strict isolation and infection prevention tactics used in hospital setting, as we do in our nursing facilities and any other healthcare settings, we consider a person still to be at risk until they reach that 14-day mark. So there's a couple things that can help with that. One, almost everybody who's hospitalized has a COVID test in the hospital, and we've seen virtually everybody who we've seen come back to KCC communities. And then we usually test them after they've been out of the hospital if they're in our nursing facility or personal care facility. And those are done usually several days apart. Having 2 negative tests and isolation for 10 days still doesn't absolutely, and some of that isolation, can count from the hospital, still doesn't guarantee us they're free. recently, one of the area hospitals, there was a case of somebody admitted to psychiatry, acute care psychiatry unit, who tested negative, was on quarantine for, I think, 7 days, and then came out because they had tested negative, had no symptoms. 2 days later, they have symptoms. And 2 days after that, 6 other people on that unit have COVID infection. So this virus can spread very quickly. So those quarantine periods are for everyone's safety, including, the safety of all of our residents.
Thank you. Dr. Lawrence, please help us understand why we need to place a bubble, per se, around residents who reside in Westmoreland, Cumberland, Burbank, and Audeland, and a bubble meaning extra precautions, such as visitations from families or from visitations from their friends who reside in independent living.
Well, we know from outbreaks in the last, going back 3-4 months, where many nursing facilities in our area had very significant outbreaks of COVID-19 infection. We know that it spreads very quickly and in an occult fashion, in that you can't see it or tell where it is or where it's going. We know that happens. We know that COVID-19 infection is brought in from the outside, like influenza in nursing facilities. It's not a nursing facility resident who develops influenza and spreads it. It comes in from staff members who live out in the community and end up bringing in infection, and can be infectious before they even have symptoms. And that applies to COVID as well. People can be infectious for 2 days before they have any symptoms. And people who are asymptomatic can be infectious for 10 days from whenever they acquire the infection, because they have no symptoms. We don't know when that is. So the only way to protect this most vulnerable of our American population, nursing home residents, is to really limit things in terms of outsiders, including visitors, coming in. Now, there's always been ways we've allowed for compassionate visitation on a very limited basis, but all facilities in the area really are still on very restricted visitation, and I think will be until we get to the end of this pandemic, just because the residents are just so vulnerable.
Thank you, Dr. Lawrence. Dr. Lawrence, residents are planning to travel in the next few months, gather around a table for the holidays, winter and warmer climates, international travel, travel within the United States. Can you share your perspective on travel within the United States, airline travel, gathering with family and friends, and the risk of infection and quarantine?
Well, we don't really know. We can't really quantify the exact risk of airline travel, for example, or international travel. We only know that it's the highest risk thing you can do in terms of travel. Travel in a private car with people who are in your household is probably safe. What happens when you get there is a different story. But there's no good news about saying that travel looks safe. The only people who are safe from COVID to travel is people who've had COVID recently. They're immune for a while, and we don't know if that immunity lasts more than 3 months or not. We think it lasts at least 3 months. There have been very few cases of people getting COVID again. It's in the handful worldwide. But most experts believe that could probably happen. But unfortunately, until there is an effective vaccine that is fairly widely distributed, travel probably we're not going to be able to say it's safe. It's probably the last thing we'll be able to say, safe to resume air travel. Having said that, I'll say this. I don't think anybody of us are going to be flying on an airplane without a face mask in the next 30 years. So I think one of the things that's here to stay is probably wearing face masks on airplanes. So I wish I had better news about travel. I was talking to one of my patients in the office today who's got his tickets for the auto train to Florida. and week before New Year, the week between Christmas and New Year's. And the way things are now, you wouldn't want to be on the auto train as a group. It's same as an airplane, in my opinion. But stay tuned. I don't think we're there yet to be able to reliably say when it's going to be safe to travel. What we know is, these 14 or more states where the hotspots were, a hotspot can develop any time. I wouldn't want to go to Pittsburgh right now compared to our area. I just got off a call before this with the state Department of Health, Department of Human Services, reviewing where all the current outbreaks in nursing facilities were. And, the Pittsburgh area and the Allentown area that seem to be where things are hot. So just know that if you're going to travel, you have to be extremely cautious and investigate things before doing so.
And finally, Dr. Lawrence, this question is twofold. We hear so much about the flu season mixing with COVID-19. The signs and symptoms are similar. What would your recommendation be for our residents in all our communities to manage this complex situation? And then, Dr. Lawrence, have testing protocols been improved to address multiple viruses in one test?
So the good news is, because influenza is spread the same way COVID-19 is spread by, aerosol respiratory spread primarily. And we're doing so much to prevent COVID-19 spread that way. We're also preventing influenza spread. And influenza is somewhat more predictable than COVID-19 in terms of trying to control it. First of all, we have effective vaccines and have for decades. And we usually have pretty high vaccination rates among our residents. Further good news supporting the evidence that everything that's being done to prevent COVID is probably preventing influenza is in Australia, where it is influenza season right now. There are relatively few cases of influenza. So we're hoping we'll have that same protection against influenza next year or this year, because we're all social distancing, wearing masks all the time, and so forth. Having said that, it's still highly recommended that everybody get a flu shot, because that's the best way, regardless, to prevent influenza. What we know from the end of last winter, is that people can get influenza and other viruses like respiratory syncytial virus and COVID-19 at the same time. Back in March, I saw a couple of cases where somebody had an influenza test come back positive, and they were treated with the antiviral for influenza, which, by the way, is not effective for COVID-19 infection, but it's effective for influenza. And they still had symptoms, so they got another test, this time for COVID, and they had COVID. So the so-called co-infection of COVID with other viruses, including influenza and respiratory syncytial virus being the two most common things that we worry about, can happen. This year, we're going to be testing for all three of those viruses simultaneously. So anytime, really starting now, that somebody has symptoms of respiratory infection, such as fever, cough, runny nose, and so forth, we're going to be testing for all three of those viruses: COVID, influenza, respiratory syncytial virus. And the swab is actually the test that we've actually tested for another half a dozen viruses, and also tests for some bacterial pathogens. So we'll be testing for all those things pretty much at the same time, starting very soon. And the laboratory and the lab that we use has those test swabs available for that testing. So we're hopefully looking forward to a very quiet year of influenza while we continue to battle this pandemic.
Thank you, Dr. Lawrence. At this time, I will invite Lisa Marsilio and Donna Taylor if they have a follow-up question or comment. Lisa?
Dr. Lawrence, thank you very much for all those very eloquently answered questions. And I too have been thinking about influenza and all the protection that we have put into place with our residents from an infection prevention standpoint. And I really appreciated you mentioning that with, maintaining your social distancing and masking. I think that's a really important point to drive home to our residents. We've done so well thus far. Let's continue this as we battle COVID, but let's also try to mitigate the flu. So I thank you for all those great comments. I think they're really going to appreciate hearing that.
Good.
Thank you, Lisa. Donna, unmute yourself and then we'll have you ask a question or comment.
Sure, and I might like to add thank you too for your guidance during this pandemic and supporting our health centers, both at our Kendall and our Crosslands campuses. And the testing that we have been doing has proven a successful strategy. So we're very pleased thus far and happy to report that we have no COVID positive staff members or asymptomatic staff members that we're aware of at this time. But as you know, testing continues here on our campus. Can you comment just briefly about, on the news, people have heard about the testing machines that are being sent to nursing homes and your opinion of the validity and the reliability of those tests?
Yeah, so you're referring to the so-called point-of-care antigen test machines, which are being provided. The machines are being provided free of charge to all nursing facilities. Just found out that probably all freestanding personal care facilities will be receiving testing machines. As I mentioned, the antigen test is a weaker substitute to the traditional PCR test, but there are still very significant shortages of PCR testing, both in the absolute number of tests that are available and the turnaround time of the testing. Once the turnaround time gets much beyond 48 hours, it's just really difficult for everybody waiting for those test results. So the antigen tests are quick, but they're not as reliable. And frequently, whatever the result is on an antigen test, whether it's positive or negative, it may need to be rechecked by a PCR test. So they're tests that were developed, hopefully, to be good substitutes for the PCR test, and so far all of them are not as reliable. So they may help in times of shortage. They may help when we need a quick answer until another test is available, but they're not going to be the savior to our testing limitations that will be a problem in the country for weeks, if not longer. So we have the tests. We have a couple hundred of the tests, which really would barely test all of our staff once. But we're looking for ways that they can fit in where need be when it looks like we may have a shortage or other limitations.
Thank you.
Well, Dr. Lawrence, that concludes our program today. Thank you again for joining us, for your guidance. Stay well, stay safe.
Thank you very much. Appreciate everybody's time.